After reading this module, you shall be able to first understand various concepts of healthcare financing, secondly, to have information about various sources of financing, thirdly, to identify the role of good health in economic development, fourthly, to identify the share of GDP spent on health sector, and lastly, to highlight the resource constraints in health care system. All over the world, health is regarded as a crucial element of human development. World Health Organization, that is WHO, identified health as a human right as well as common denominator for ensuring social well-being. Thus, we can say that empowerment of people comes from the freedom they enjoy, and this includes among others the freedom from poverty, hunger and malnutrition, freedom to work and lead a healthy life. This definition is given by A.K. Sen in the year 1981. There is a direct relation between economic growth and improved health indicators. Health contributes positively to economic progress, consequently leading to improvements in the economic development of the country because healthy population live longer and hence productivity. Access to healthcare or financing of healthcare varies across countries, groups and individuals, and it is mainly affected by the socio-economic conditions as well as by the health policies followed in the country. Different countries adopt different healthcare policies according to their healthcare goals. Healthcare can be assessed either privately or at the government's cost. Whatever the case be, according to WHO, a well-functioning healthcare system requires a robust financing mechanism, a well-trained and adequately paid workforce, reliable information on which to base decisions and policies, and well-maintained health facilities and logistics to deliver quality medicines and technologies that can be found on the website www.who.int. Every nation aims at well-functioning healthcare system, but underdeveloped and developing nations face difficulty in achieving this objective because of low level of income and expenditure, specifically in public sector. As India is not an exception, it also faces the problem of maintaining well-functioning healthcare system. Around 4% of GDP is total spending on healthcare of country, and out of which government spending is only about 1% in the year 2011. Accordingly, India's healthcare system is characterized by the non-availability of drugs, lack of advanced laboratory facilities and equipment, lack of healthcare staff and poorly financed public health system. But in recent decades, Government of India has launched various plans focusing on healthcare such as National Rural Health Mission, that is NRHM, National Health Mission, that is NHM, Rashtriya Swasthya Bima Yojana, that is RSBY, Janani Suraksha Yojana, Polio Abhiyan, etc. Consequently, the birth rate, death rate, maternal mortality rate, etc. have successfully declined over the period of time. In the present context, main focus of the study will be on the sources of financing of healthcare, coverage of healthcare facilities and resource constraints and bottlenecks of healthcare system in India. Now we move on to conceptualization. We start with healthcare. In simple words, healthcare is the maintenance or improvement of health via the diagnosis, treatment and prevention of disease, illness, injury and other physical and mental impairment in human beings. This definition is given by Wikipedia. As per World Health Organization, Constitution defines health as a state of complete physical, mental and social well-being and not merely the absence of disease or infirmity. According to this definition, government is not responsible only for providing health services to their citizens, but also to ensure that these services should be made available to all without any discrimination, which will contribute to social and mental development of citizens in addition to physical well-being. Now we move on to health system. Health system is a composition of all the organizations, institutions and resources whose fundamental aim is to serve for health and to improve health facilities for the society. Now we have healthcare financing. Healthcare financing means the mobilization of the funds for the healthcare. In other words, allocation of funds to the different regions and population groups for the healthcare services is called healthcare financing. It is also the way for paying for healthcare services. Now we have contribution of health improvements to economic development. There is two-way relation between the health and economic development. On one side, economic development contributes to good health and nutrition, and developed countries invest significantly in medical care and public health measures. On the other side, improvements in health or better healthcare contributes to economic development through improved productivity, better human capital, etc. The contribution of healthcare in the economic development is shown, the points discussed here, such as shown in the figure. The figure shows role of improved health in economic development. On the basis of this table, we start with first, improvement in productivity. A better healthcare service assists the productivity of the workers in the sickness days or through increased output while working. Secondly, we have demographic changes. The investment undertaken by government for family planning and healthcare can result in reduction in poverty by adopting the optimal family size. Similar investment in healthcare will lead to socio-economic implications such as fall in birth rate, increase in life expectancy, increase in saving rate of workers, etc. These positive changes in demographic factors will positively contribute to economic development. Thirdly, we have health and capital formation. Better health means enhanced productivity, which lead to more earnings and thus incentive to save more, resulting in capital formation. Accumulation of capital acts as a fuel to economic growth via investments. Similarly, companies are more interested to invest in healthier and better educated workforce. Then next we have human capital. Improvement in nutrition and reduction in disease, specifically in childhood, lead to improved cognitive development, which enhance the ability to learn. This enhanced learning ability will contribute to human capital, which is one of the important components of economic growth. This definition is given by A.S. Bhattacharya and Fowler in the year 2015. Now we move on to sources of healthcare financing. Generally, there are three main sources of funding healthcare in any country, namely public expenditure, private expenditure, and external resources. These are briefly discussed here. We start with public expenditure. The expenditure incurred by the government, whether central or state or local, on the healthcare in any way is known as public spending on health. Government has numerous ways to increase the expenditure on healthcare up to sustainable levels, such as increase in tax rate, introduction of new taxes, fiscal deficits, power of synergy, etc. Generally, public health expenditure comprises of recurrent and capital spending from government, that is central or state, budgets, external borrowings and grants, and social or compulsory health insurance funds. Broadly, it covers the provision of preventive and curative health services, family planning activities, nutrition activities, and emergency aids particularly designed for the health. This definition is given by the site worldbank.org. Now we have private expenditure. Private expenditure plays a vital role in overall health financing, that is, major proportion of health expenditure is incurred out of pocket expenditure in the developing countries. Private health expenditure includes direct households, that is out of pocket spending, private insurance, charitable donations, and direct service payments by private corporations. This again can be found on worldbank.org. Then we have external sources. External sources are those which are not the part of countries' own sources and originate from international organizations and other countries. These resources are also part of total health expenditure of the country. Again, we can found on worldbank.org. Now we move on to healthcare financing in India, the channels. As discussed earlier, there are three main channels of financing healthcare, namely public, private, and external sources. In case of India, the classification is somewhat different, but the components are similar. Broad structure of healthcare financing in India is shown through the figures. We start with first public or government spending. By the end of 11th 5-year plan, that is from the year 2007 to 2012, the government spending on healthcare sector was merely 1.04% of the GDP. Out of this, the share of central government spending was 0.35% and that of state government was 0.68% of GDP. This data has been collected from Niti Aayog 2015. Although government expenditure on healthcare accounted 1/4 of total health expenditure, still it plays a major role in terms of planning, regulating and shaping the delivery of health services to society. As a result of this, large and widespread public healthcare system grew with the passage of time. Healthcare service is provided through various channels under government, namely, first, Ministry of Health. That is, Ministry of Health and Family Welfare is responsible for health policies and programs and control of major as prevention and control of major communicable diseases and controlling the spread of seasonal diseases, outbreaks and epidemics through technical assistance. Ministry of Health Services incurs expenditure directly under central schemes or through grants in aid to autonomous or statutory bodies and NGOs. In addition to this, MOHFW also work on implementation of several World Bank assisted plans for controlling AIDS, malaria and TB etc. in the designated areas. Now, second source we have public or government department and undertakings. It includes government institutions in rural and urban areas. In the rural areas, there are three institutions for healthcare, namely, first, sub-center. The first peripheral contact point between primary healthcare system and the community is the sub-center. Main purpose of establishing sub-center is to provide service in case of maternal and child health, family welfare, nutrition, immunization, diarrhea and pneumonia control and control of communicable diseases. Secondly, we have primary health centers. The first contact point between village community and medical officer is taking place in the primary health center. Main function of primary health center is to act as a referral unit for 6 sub-centers and PHCs have 4 to 6 beds for the patients. PHC indulged in providing curative, preventive, promotive and family welfare services. Third, we have community health center. The community health centers are established and maintained by the state governments. It has all the necessary equipments as 30 indoor beds with an OT, X-ray, labor room and laboratory facilities, and it also acts as referral point for 4 PHCs. The number of sub-centers, PHCs and CHCs are shown through table. Table shows that the number of sub-centers are 1.52 lakhs, primary health centers are 25,020 and that of community health centers are 5,363 in the year 2015 and in rural areas. Their number is less than the required. The table shows the number of sub-centers, PHCs and CHCs in rural areas. At the urban level, healthcare system composed of first, district hospitals and dispensaries, second, urban family welfare centers, third, special hospitals, fourth, medical college hospitals or teaching hospitals, fifth, super speciality hospitals or institutions. Now we have the compulsory government health insurance scheme or publicly financed health insurance. There are number of health insurance schemes financed by the government in order to improve the access to hospitalization services and to promote household from high expenditure of medical facilities. One of the publicly Swasth Bima Yojana launched by the central government under the Ministry of Labour and Employment in the year 2008. Other scheme is Pradhan Mantri Swasthya Suraksha Yojana. Then we have private expenditure. It includes the following sources. First, private individual household or out-of-pocket expenditure, that is OOP. Out-of-pocket expenditure is direct expenditure incurred by household on healthcare services which aim at the restoration or enhancement of the health status of individuals or population groups. It is one of the major component of health expenditure. However, with the passage of time, the share of out-of-pocket expenditure has shown decline due to increase in spending through other sources. Table shows the trend of out-of-pocket expenditure. In the year 2011, it was 87.1% which decreased to 85.9% and still remains higher as compared to other sources. The table shows the percentage share of out-of-pocket expenditure in total healthcare spending. Now, the second is corporate social responsibility. It is mandatory under the Companies Act that companies with minimum average net profit of 50 million over 3 years must spend 2% of their annual profit on corporate social responsibility activities, in which health service is an eligible component. Several such companies are already involved in health initiatives under the CSR activity. This activity is also mandatory for central public sector undertakings. Funds arranged through this activity can be channelized towards health by making arrangements for public health facilities to directly receive donations from companies with safeguards to ensure no frills funding as suggested in 12th plan as per Niti Aayog 2015. Then we have private employer healthcare fund and private or corporate health insurance scheme. Healthcare provided by entities other than government, usually some portion of income is saved in the fund out of which employer provides medical and healthcare facilities. Whereas under private or corporate health insurance scheme, employee state insurance scheme is popular. Employee state insurance scheme is a self-financing social security and health insurance scheme for Indian workers. Under this scheme, ESI Corporation provides medical and cash benefits to the employees and their families through its large network of branch offices, dispensaries and hospitals throughout India. Now we move on to external sources. It includes the funding from international institutions, both official and non-official like WHO, UNICEF, World Bank, UNDP, etc. These institutions provide funds mainly to underdeveloped and developing world for maintaining their health standards under bilateral or multilateral arrangements or through aids. Now we move on to share of GDP spent on healthcare in India. Though India has achieved impressive economic growth along with increase in public expenditure on health in 11th 5-year plan, yet the total expenditure on healthcare in year 2011 is 4.1% of GDP. It is empirically proven fact that unless and until nation spends at least 5 to 6% of GDP on health, particularly from government side, the basic healthcare needs are seldom met. Government share on healthcare is marginal, that is 1.04% of GDP, that is less than 30% of total health spending in the country. At present, total health expenditure is 4.5% of GDP, which is less than the norm suggested by WHO for developing countries, that is 6.5% of GDP. This data is given by J. Chaudhary in the year 2015. Government expenditure on healthcare is shown in table. The table 3 shows government expenditure on healthcare. The table highlights that the public expenditure is increasing in the nominal terms. Overall expenditure has increased 4 times from 2005-06 to 2014-15. The major share in public expenditure is of state government, whose data reflects increasing trend over the period of time, that is rupees 23,129 crores in the year 2005 to 2006 to rupees 1,05,300 crore in the year 2014 and 2015. Whereas the central expenditure also shown 4 times increase in its expenditure on healthcare services, that is from rupees 11,640 crores in the year 2005 and 2006 to rupees 44,238 crores in the year 2014 and 2015, but its share remains lesser than that of state. Now we move on to comparative picture of healthcare financing in various nations. Table shows the share of GDP spent on healthcare services in different countries. Table clearly shows that in highly developed nations, state government consider funding healthcare as prime responsibility. Even their citizens have capacity to finance their own health services independently, which is high enough. But in comparison to this, in India, the contribution of government is fixed at 1% of GDP for many years, which means state cannot afford the required resources for the health services. Table shows percentage of GDP spent on healthcare in different nations. In the developed world, citizens can afford costly health facilities out of their pocket. Still, there is significant proportion of GDP spent on maintaining better healthcare facilities. In US, the share of GDP spent is 16.9%, In France, it is 11.6%. In Switzerland, it is 11.4%. In Germany, it is 11.3%. In Japan, it is 10.3%. In UK, it is 9.3%. And in India, only 4.5% of GDP. Now we move on to the discussion of resource constraints in healthcare system. There is paradox in the health sector of India, that is, on the one hand there exists largest generic drugs industry which exports medicines to more than 100 countries, due to which India is known as pharmacy of the world. On the other side, India faces underperformance in healthcare services, that is, inability to deliver affordable health services to its over 1.2 billion citizens. This data is given by M. Golcha in the year 2015. This poor performance is due to lack of public sector spending and thus further imposing resource constraints on health sector. Some of the resource constraints or challenges of healthcare sector in India are enlisted here. First, lack of financial resources. Lack and low level of investment on healthcare in the country is one of the basic reasons behind the poor functioning of health system and ill health indicators. Moreover, much of health expenditure through out-of-pocket source makes middle income families poor families many times. Besides taking care of poor families, public expenditure is also required for better infrastructure, expansion of health workforce and provision of essential drugs free of cost. As stated earlier, in India, public expenditure on health is around 1.2% of GDP, which is much lower as compared to other developing countries of the world. Government should increase its expenditure on health up to minimum 3% of GDP by the year 2020 and 4% by the year 2025. This source is given by Planning Commission of India in the year 2011. The second point is lack of manpower in rural areas or primary health care. There is need to strengthen primary health care because rural areas has lesser share of healthcare facilities as compared to urban areas. Rural areas are featured by the continuous shortfall in the availability of health sub-centers by 20%, primary health centers by 23% and community health centers by 32%. This is shown through table. The table shows planned centers versus centers in place. Then we have the third, human resources for health. There is severe shortage of skilled person or human resources in health sector of India. The public health sector face shortage of 85% specialist doctors, 75% doctors, 80% laboratory technicians, 53% nursing and 52% ANMs. This data is provided by D. Nandan and D. Agarwal in the year 2012. Thus, the need of time is capacity building in health system in order to achieve the aim of universal healthcare in India. Then we have fourth point, that is weak governance and accountability. Health is under the state list as per the Constitution of India. Accordingly, state governments are responsible for providing healthcare facilities. Surprising fact is that 1/3 of the funding for health is incurred by the central government, since the total share spent by both central and state is just 1% of GDP. So both central and state governments are required to work hand in hand to ensure efficient delivery of health services. So there is need of proper governance and accountability on the part of both central and state governments' various healthcare department functioning. This data is provided by V. Patel etc. in the year 2015. Now we move on to the government initiatives. Government of India has undertaken various steps for providing financial assistance for healthcare to its citizens through various health focused schemes and programs such as National Rural Health Mission, that is NRHM, which was launched in the year 2005 with the aim to provide accessible, affordable and quality health care to the rural population, particularly to vulnerable group. National Urban Health Mission, that is NUHM, launched in the year 2013 with the aim to meet healthcare needs of the urban population, particularly urban poor and slum dwellers, by providing them essential primary healthcare services and reducing their out-of-pocket expenditure for treatment. Rashtriya Swasthya Bima Yojana, that is RSBY, with aim to provide protection to BPL families, financial liabilities arising out of health shocks that involve hospitalization and universal health coverage, that is UHC program, etc. Then we have universal health coverage. The strategy of universal health coverage model is proposed under the 12th five-year plan of India. Universal health care model in its simplest form means access to quality, effective and affordable health services for all without imposing financial burden. This is simplified by T. Connell in the year 2014. The three greatest challenges being faced by India's healthcare system are accessibility, availability and affordability. This requirement is given by Planning Commission of India in the year 2011. Ultimately, this leads to very high cost of pocket medical expenditure. The government should institutionalize UHC as a way to remove barriers to good health and expand access to quality, affordable care. In the UHC model, all citizens should be entitled to a comprehensive package of healthcare services and have access to public health and accredited private facilities for attaining services such as diagnostics, medicines, vaccines or surgeries as an entitlement without having to pay at the point of use. This is given by M. Golcha in the year 2015. Through this, it also aims at reducing social inequalities. Now finally, we are going to make a summary of what we have discussed so far. First, health is a crucial element of human development. Second, there is a direct relation between economic growth and improved health. Third, improved health leads to enhancement in productivity, formation of human capital and favorable impacts on demography. Fourth, healthcare can be accessed either privately or at the government cost. Fifth, generally healthcare is financed out of private and public expenditure. Sixth, in India, share of GDP spent on health is 4.5%, which is much lesser as compared to other developing nations. Sixth, major source of financing healthcare in India is the out-of-pocket expenditure. Seventh, India's healthcare system is characterized by the non-availability of drugs, lack of advanced laboratory facilities and equipment, a rigorously constrained healthcare staff and poorly financed public health system. Seventh, Government of India have launched various schemes for assisting healthcare services to poorer sections of the society, namely NRHM, NUHM, RSBY, UHC, etc.